But I am thankful for all of you for joining on today. And this is a pretty small group who's on the call, so it's pretty intimate. If you have any questions, concerns, cases you want to talk about, feel free to either unmute and ask or even send me a chat message and I can repeat the case to the group and talk about those things. I don't think that my presentation will take a full hour by any stretch, so we'll have time to go through any cases if you like. Feel also free to contact me at the end. I'll put up my email. I'm always happy to answer questions. And I'm just going to verify that the audio is working. Okay, looks like we're on. All right, I'm sorry for that delay. So the topic for today is cardiac ablation in children, who, why, how, and when. Specifically when to refer, but also to give people a background and a bit of comfort if any of your patients are undergoing this procedure or have in the past, just to know what goes on behind the scenes and what technically and logistically this actually looks like for patients. So the objectives of today are to, hopefully at the end, you'll be able to identify the types of arrhythmias commonly seen in pediatrics and the therapies available, to understand the indications for cardiac ablation in pediatrics, and to appreciate the logistics and methods for ablation procedures. Electrical heart disease, arrhythmias. Some people, even adult cardiologists, are often surprised to hear that children have these things, but of course they're also at risk for arrhythmias just like adults. This might be benign ectopy, premature atrial or ventricular contractions, tachyarrhythmias, of course, supraventricular tachycardia, and ventricular arrhythmias. Children can have non-sustained VT or VT, less oftenly VF, and that's a bit of a different entity, ventricular fibrillation. And of course, the slow rhythms, bradycardia, heart block. Today we're going to be really focusing on premature ventricular contractions, SVT, and ventricular arrhythmias, and their treatment with catheter ablation. So who's at risk for arrhythmias? Again, we said that kids can. And in structurally normal hearts, this can occur very sporadically. It's not typically inherited and does not reflect an underlying heart problem, but it's just an extra electrical connection that can intermittently fire. There are also inherited arrhythmia syndromes, which we won't talk about today. And of course, our patients with congenital heart disease are at risk of arrhythmias due to pressure or volume overload, as well as chronic cyanosis. There's acute postoperative arrhythmias, as well as a risk for late arrhythmias, years to even decades following heart surgery related to scar lines and hemodynamic changes. There are also acquired heart conditions which can increase the risk of arrhythmias, including myocarditis. So the first step is usually documenting, and the gold standard for that is going to be a 12-lead electrocardiogram. That's going to give us the best information to prove what a patient is feeling, or if they're not feeling it, sometimes we catch it by accident or incidentally. During symptoms is going to be the ideal time. Many things don't show up unless the patient is actively in an arrhythmia, and so getting an EKG during symptoms is our holy grail. When that's not possible, we also can use Holter monitors to document the rhythm. And this is helpful for initial diagnosis if the episodes or a patient is complaining of symptoms that are very frequent, at least once a day, and they're brief and not requiring a trip to the emergency room. So a Holter, we might get lucky in a day and document an arrhythmia. We also have event monitors and loop recorders for less frequent or short episodes or sudden episodes that are difficult to capture with an EKG. These are various types, but they're typically portable, battery-operated devices that a patient can have for 2 to 4 weeks at a time to try to capture their arrhythmia. They're handheld, or they attach to electrodes on the skin or a patch on the skin, and these provide a single rhythm strip for symptom-rhythm correlation. Can be very helpful. In some cases, it can still be a little bit cryptic and hard to interpret, but also great. Finally, we do have the ability to do an implantable loop recorder, which provides 3 years of continuous monitoring. And this is a very small device. Here in this picture, the older model is big like a jump drive, and the new smaller version, this is a Medtronic version called a Link, which is really tiny, and this is implanted in our cath lab just underneath the skin on the chest. And this can automatically record arrhythmias as well as patient-activated heart rhythms during symptoms. So these are great devices if the stakes are high or if it's been very difficult to document. Most of what we're talking about is SVT, supraventricular tachycardia. It's actually an umbrella term, and it's often used to talk about these typical AV reentrant tachycardias that either are by an accessory pathway, like WPW, or AV-NRT, AV nodal reentrant tachycardia, from dual AV nodes. But of course, SVT can include ectopic atrial tachycardia, flutter, fibrillation. These are very rare in young individuals, but can be seen. And junctional tachycardia, another rare form of SVT in structurally normal hearts. Pediatric SVT is common. Estimated 1 in 250 children will have some type of SVT. It's the most common arrhythmia in pediatrics. Again, typically accessory pathway mediated across the mitral or tricuspid valve, or AV nodal reentry within the AV node itself. Less commonly, an automatic arrhythmia, an ectopic atrial tachycardia coming from somewhere in the right or left atrium other than the sinus node. Then there's ventricular tachycardia, which often strikes fear in the hearts of providers, and we know that it can be shocked out with a DC cardioversion. But in truth, this can actually be another common and often benign arrhythmia in pediatrics. PVCs, for example, 15% of infants might have PVCs. 40% of adolescents may be found to have PVCs, and in congenital heart disease, even higher proportion. Ventricular tachycardia, the incidence is less well defined, and many VT patients will have a history of congenital heart disease, but we also see this in the structurally normal heart. Bellhausen's tachycardia, or left ventricular tachycardia, is one example. And this looks very narrow. It looks a lot like SVT, but it has a superior axis. It's often well tolerated, and the trick is that it won't break with adenosine. So if there's a patient in the emergency room with a narrow complex tachycardia that doesn't break, one of the possibilities is it's VT. Look for that superior axis. It will respond to calcium channel blocker, so IV verapamil would actually be the treatment. Outflow tract VT, we often talk about RVOT, or right ventricular outflow tract VT, is a very common source of a benign ventricular ectopy. It might be sustained or non-sustained, and it's usually very well tolerated hemodynamically. And of course, scar-related in our congenital patients. This might be a scar from a ventriculotomy during congenital heart repair, or it might be due to a primary myopathic process, such as myocarditis or right ventricular cardiomyopathy. Here's an example. This is a fun screenshot of a patient who was being observed in the hospital. Believe it or not, he broke his toe, and during evaluation in the emergency room, he was noted to have an irregular heart rhythm. This is a teenager. And sure enough, his electrocardiogram looks like this, where there are 2 to 4 beats of sinus, followed by 4 to 7 beats of non-sustained VT over and over and over again. So this is a repetitive VT, more precisely repetitive non-sustained VT, and this is completely asymptomatic. It's not bothering the patient at all. The big question is it bothering the patient's heart? This could lead to ventricular dysfunction, but doesn't always, and may actually be a totally benign rhythm. Looks very impressive. So why should a patient have ablation? Well, first let's talk about treatment options for pediatric arrhythmias. The first is simple observation. If it's not a dangerous arrhythmia, which many pediatric arrhythmias are not, simple observation is fine. If it's not bothering the patient very much and it's not life-threatening or causing them harm, then we might not have to do anything about it. The second option is medications, which could take the form of a daily prophylactic or maintenance medication to help prevent the recurrence of their arrhythmia, or a pill-in-the-pocket therapy where they don't take a medication until they have an event, then a one-time dose would be used to try to terminate the arrhythmia. And the third option for many arrhythmias is ablation therapy, which is going to be what we talk about for the rest of the day today. Of course, we have other things like pacemakers, defibrillators, surgical therapy for the more complex patients. So our common arrhythmias, what are the implications of these? Well, symptoms, of course. Are these causing disruption to their daily activities, or are the symptoms so severe that the patient is incredibly uncomfortable and just can't tolerate their tachycardia? It could result in ventricular dysfunction, specifically if the arrhythmia is incessant and or unrecognized. So PVCs, if they're very frequent PVCs, if they're all day long, 30% of the day, the patient may not be aware of them, but it might be enough to cause ventricular dysfunction. Similarly, an ectopic atrial tachycardia might have a relatively slow rate and not be detected on exam or by the patient, but because they're chronically going at this constant speed of a different type of rhythm, that might actually induce left ventricular dysfunction. How much is too much is really hard to say. People like to try to quantify how many PVCs, for example, in a day. Is it more than 10% increases the risk of dysfunction? Is it more than 25%? I don't think personally that there's a good answer. I've had patients with 75% ventricular rhythm and their function is normal. We might encounter a patient with 5% ventricular ectopy and they have left ventricular dysfunction. So it's a bit unpredictable and every patient is, of course, a unique case. Sports participation and physical activity. Most arrhythmias are not they don't require restriction to activity from our perspective, but many children will restrict themselves or limit themselves because either their symptoms happen during exercise or they're so nervous that it will happen that they don't even want to participate or travel or do activities. Risk of sudden death. Obviously, this is an incredibly important one. It's also incredibly rare. Most SVT is not life-threatening, doesn't make people faint even, can be uncomfortable. There are rare exceptions. One of the main ones is Wolff-Parkinson-White syndrome, in which patients can have pre-excited atrial fibrillation, where if all those rapid and chaotic atrial beats are conducted down the WPW pathway, suddenly you have ventricular fibrillation and cardiac arrest. There are other implications in the lifestyle, such as disqualification from jobs or certain activities. So there are many military and law enforcement, or, for example, being a pilot, where if you have certain conditions like WPW or SVT, you may be disqualified from participation. Medications have standardly been the first line of therapy. But of course, they do have potential side effects, and it can be pretty difficult to be compliant with a daily medication, especially in the teenagers. Side effects are an issue, and so this is not always an easy option for people. The radiofrequency ablation. This has been around for a couple of decades now, initially used in the late 80s in adult arrhythmia management, and it started to be used in pediatrics in the early 1990s. Prior to radiofrequency ablation, it was a DC ablation that was actually done, which by reports from my mentors and those in the field who were present during that era of pediatric arrhythmia management, was a pretty graphic and impressive procedure. It's imprecise, and there were actually significant risks. So that was quickly abandoned. But since radiofrequency has come along, it's really become a mainstay of therapy. The alternatives to ablation, again, that we talked about are medications. Ever since the early 90s, there have been different reports on the indications for pacing in pediatrics. Here in 2000, it was updated again. And over the years, this has evolved. The most recent recommendations come from the Pediatric and Adult Congenital Electrophysiology Society, or PACES, and the Heart Rhythm Society. This expert consensus statement came out in June of last year, 2016, in Heart Rhythm. And it's a great document, probably not read by many outside of electrophysiology, but it actually has really good summary and background information on arrhythmias, all the various types of arrhythmias. Gives a little bit about ablation as well and the techniques and technology there, and then provides specific recommendations for different diseases. For example, in narrow complex tachycardia, they talk about Wolff-Parkinson-White. What about atrial fibrillation in the adolescent? So this is a really good resource that goes through the specifics of different diagnoses, as well as special populations, including those with congenital heart disease or infants and small children. I'd like to put in a plug for PACES, the Pediatric EP Society. On our website, we've been really working over the last couple of years to improve the website and make it functional for providers and families in addition to ourselves. And there are patient resources on there, also places where you could go and search for a heart rhythm specialist in any state or country. So a great place to start looking at, and I think we'll continue to build that and make it a good resource. Arrhythmias can be really confusing for families and providers, so there's a level of discomfort, and having some background information from a trusted source is always really helpful. Okay. So I summarized very briefly some of the Class 1 indications for ablation in a structurally normal heart. Again, among guidelines and consensus statements, a Class 1 indication is one in which there's evidence or general agreement that a given procedure or treatment is beneficial, useful, and effective. So basically, it is recommended. If you have a Class 2A recommendation or a Class 2B, it might be that there's limited evidence. One could elect to do that therapy, but it's not as strongly recommended. So the Class 1 indications from that paper, just to summarize very briefly, include narrow complex tachycardia that's recurrent or persistent, and it may or may not result in ventricular dysfunction, when medications are not effective, or if there's intolerable side effects, Class 1 indication for ablation, or if a patient or family wishes to avoid chronic medications. Many families are averse to being on medications. And of course, if the rhythm is unstable or requires emergency medical care or electrical cardioversion, that would be a Class 1 indication for ablation. In patients with WPW, clear indication if you have had a cardiac arrest or a syncope that's suspicious, or pathway properties that are higher risk or indicate a higher risk, definitely Class 1 indication for an ablation. For ventricular arrhythmias, frequent PVCs is a Class 1 indication with ventricular dysfunction. Ventricular tachycardia is also an indication, and these are, again, when medications are not effective, if you've had intolerable side effects, or simply as an alternative. Again, this is becoming a first line of therapy for many rhythms in pediatrics. So how and when do we do this? Well, this has become increasingly used and is now often first line, as I just said. It has multiple benefits. It's diagnostic. It can confirm the presence of an extra electrical connection or the inducibility of SVT. It's prognostic. For example, in WPW, we test exactly how fast that pathway can go. And if they have atrial fibrillation, how likely is it or how risky is it for the induction of ventricular fibrillation? And it's also therapeutic, of course, with our ability to eliminate the arrhythmia substrate in their SVT or VT. Traditionally, this was always done under fluoroscopy or X-ray, which is equal to radiation exposure, and we know that there's a risk of skin burns and longer-term risk of malignancy. There's a principle of ALARA using as low as reasonably achievable radiation, and since the early 2000s, there are several non-fluoroscopic imaging systems which have become routinely used. I use this in nearly every case. I'd like to say every case. And many of our cases now, not only have we reduced radiation from the old 30 to 40 minutes per case down to a couple minutes, but many of our cases we use zero radiation at all. So it's been a really great advancement, not just for that, but for some reasons that I'll show you in the coming slides. So the goal of the cardiac ablation is permanent cure. We want to eliminate the substrate, eliminate the ability to have SVT, and eliminate a patient's symptoms. Therefore, they don't need to be on chronic medications. We can reduce anxiety associated with their arrhythmia, and in some cases, eliminate the risk of sudden death from their arrhythmia. These are interventional catheter-based procedures that are typically done as an outpatient visit. Sometimes they'll stay overnight if they're having any nausea or need extra monitoring, but most patients come in that morning and go home that afternoon or evening. We do this via femoral venous access, most commonly. Infrequently, we'll have to put a catheter in the internal jugular artery in the neck. Unlike adult cardiac caths, we don't use the radial artery, so predominantly we're using our femoral veins. And we may place between 1 and 4 catheters and IVs into those veins. Again, very infrequently we need to obtain arterial access to go to the aortic root or to the left ventricle. But there are no sutures or scars. These are all catheter-based. I do these procedures in the cardiac cath lab here at Children's National Medical Center, also at Inova Fairfax Hospital. We have a new agreement and an evolving agreement where we want to be able to provide our patients in Northern Virginia with the option of doing their procedure there and not having to drive to the city, but both are available for families. We do these under general anesthesia. Sometimes we want to have them awake, but very infrequently. So part of pain-free pediatrics, this is under general anesthesia, typically with patients intubated or with an LMA. The procedure itself takes about 3 to 4 hours, including getting them to sleep, getting IV access, and then waking them up at the end. After that, they're observed in our recovery unit for about 5 to 6 hours and then discharged to home. Typically, they're out of school for about 1 to 2 days, including the procedure itself. If they feel well the following day, they can certainly go back to school. They do have a week of no sports, and that's to allow the groin access sites to heal. I'm not worried about the heart healing. This is really just about those venipuncture sites in the femoral veins and making sure that they've fully healed. So what do? So we use intracardiac electrical signals and pacing maneuvers to evaluate the normal conduction system and to try to induce the arrhythmia. We then want to localize the arrhythmia substrate. What is it that's actually allowing the tachycardia? Is it an accessory pathway across the tricuspid or mitral valve annulus? Is it dual AV nodal physiology and normal variation within our conduction system? Is it an ectopic focus that's firing automatically, such as EAT or PVCs or ventricular tachycardia? Or if it's scar-related, we look for the scar and identify the circuit around the scar. Finally, we want to eliminate that arrhythmia substrate by doing an ablation. And radiofrequency is using heat, where the tip of the catheter actually heats up to create a tiny scar at that site, or cryoablation, where the catheter freezes onto the myocardium to create the scar. Heat gives us a little bit higher recurrence-free result and is slightly more effective, but if we're close to something dangerous like the AV node, cryoablation has a less depth to the lesion and therefore less likelihood of causing AV block. So our non-fluoroscopic imaging system, what does this look like? Again, this is our 3D mapping system that allows us to create a model of the heart chambers that we're going to be working in. We can visualize the catheters moving around the heart without stepping on X-ray. We can create a map of the arrhythmia substrate or find the earliest timing of it, and then localize our ablation lesions, so keep track of what we're doing. Here's a couple of the computer systems. There's many computers that are in the room, as you'll see, and this is a picture of 2 catheters. You can see the silver electrodes in these rings. Those are the electrodes that can sense and pace the heart. And they come in different shapes and forms and sizes. Here's a picture of our lab at Children's National. One of our technicians is here setting up the bed. So the patient lies on this long bed. We do have the X-ray in the room and always there in case we need it. There's multiple computer screens to look at various different inputs from the patient. And you'll see actually here, off on the side are also redundant computer screens. This is where the pacing is performed from. There are measurements during the study. And we have technicians as well as occasionally a colleague or someone else helping us at the computer. We stand here with the patient and manipulate the catheters. You'll see these silver tracks and this silver wall in our lab at Children's National. This is actually a hybrid Cath-MRI suite. We're currently doing a research study as an example of how this is beneficial, where after an ablation for ventricular tachycardia, a patient can, under the same anesthesia, slide into the MRI suite and get an MRI scan. We're looking at this to see if we can see the lesion from the ablation on the MRI, and how does that visualization correlate with recurrence or efficacy of our ablation procedure. So back to the lab. I'm going to play a couple of videos. I might skip through these. They're a little bit long and boring, but this is our game. Seems like a video game. This is our procedure. So here you see the catheter floating, and I'll tell you that this has come in from the right femoral vein, and is now floating up the IVC. And as it touches the wall, it creates this geometry, or the gray map. At the bottom, we have surface electrocardiograms, the first two lines, as well as the intracardiac signals that are going to come from our catheter when we're touching heart muscle. So we're kind of moving up the IVC. The catheter gently floats up the vein until we see a signal and know that we're in the heart. And we can do this quite quickly in the IVC. There's not much that we can injure, so we float it up and we want to create a map. We then use that to place the next catheters. So here's the top of the IVC. Now we have a catheter in the right atrium. And I'll start to play this, and you can see now this map, that's our mapping catheter. So the tip of it has this sharp spike that correlates with the P wave on the surface electrocardiogram. It's because we're touching atrial muscle, so the depolarization right there is a sharp spike. And what we do is we move our catheter around the chamber. We're going to float up and find all of our anatomic structures in the right atrium. So we are going up, and we're going to be in the SVC now. And we mark that, and then we're going to keep moving around and fill in the rest of the right atrium. We're doing this by feel. We know generally what the anatomy is and how to move the catheters. We're also looking at the signal. And for example, here, when we get a spike under the P wave and under the QRS, that's an atrial and ventricular signal telling me that I'm touching the tricuspid valve annulus, where it's getting the signal from both sides of that annulus. We also look for other important structures like the AV node, which is an endocardial structure, and it usually is right around this region on the septum of the right ventricle above the tricuspid valve, or on the tricuspid valve. And so we're looking there, and we're looking for a specialized signal to tell us that's where the AV node is. Because that's an endocardial structure, if we mechanically bump into it, we can mechanically injure it and cause heart block, which would require a pacemaker. So of course we're very cautious. We'll mark where that is, and then we'll put a catheter there in many cases to watch the conduction system the whole time. So we move the catheter around, we are building the geometry, we're taking notes on anatomical points such as the tricuspid valve lesion, the AV node, etc. Let's see, I'll fast forward a little bit here. We're watching the spikes the whole time. So here's the AV node. We put little yellow markers there. Here we're seeing at the bottom in the blue an atrial deflection, a sharp spike in the middle, then the ventricular. That sharp spike in the middle was our compact AV node signal. So we take our time and we do this because the rest of our procedure is going to be based on this map of the right atrium. All right. Once we have the right atrium connected, here's a catheter at the hip. Now we're going to put in a couple of extra catheters, again, not stepping on X-ray at all and exposing the patient to radiation. So here comes a long catheter, this blue one, and each of the gray points are electrodes that can detect and pace the heart. This is a catheter that's going to go out here into the coronary sinus. So the coronary sinus is a vein, obviously reachable from the right side of the heart, the right atrium, and it goes and it sits behind the mitral valve annulus. So when we get our catheter out there, we can actually see signals from the left side of the heart without going over there. If our catheters are on the left side of the heart, the body likes to attack foreign bodies, and it will cause little platelets to accumulate on the plastic catheters. That could lead to a blood clot that could embolize, causing injury to the coronary artery or a stroke. So obviously we're very precautious about that, and we don't go to the left side unless we need to. If we do, we give a blood thinner to prevent those blood clots from forming. But here, we're working our catheter into the coronary sinus, and it floats up to that side, and now over here we're getting all of our left-sided signals. So we repeat this for as many catheters as we need to put into place, and then we get our standard setup. So here we have catheters on this cartoon. Here's the one behind the coronary sinus, reflecting left atrial signals, and one at the apex of the right ventricle. And each of these catheters has electrical signals. So we're able to look at these electrical signals, recognize patterns, watch changes during different rhythms, and then pace the heart to try to induce an arrhythmia. So without radiation, we get to localize an arrhythmia, form these maps, and ablate the arrhythmia. On the left side of the screen, this is a map. We're looking at an ectopic atrial tachycardia focus. So the red are the earliest signals, and the color, as it fans out like a rainbow, gets later and later timing. The red dots are our lesions, where we actually put in radiofrequency burns. On the right side of the screen, this is showing a propagation map where we can actually, after we do our mapping of the arrhythmia, visually see how it moves through the heart. And you see that it originates here and spreads out like a wave front through the muscle. So we can precisely, we know where we've been, we can see the signals and the timing, and this really aids in very precise and effective ablations. So, great procedure. It's very safe and effective therapy for pediatric arrhythmias. The success rates in structurally normal hearts are quoted as high as 90 to 96%, and that, is very consistent over many years, maybe even a little bit higher. Ventricular tachycardia, when it first started, was about 60% success rate of being able to eliminate the VT during the procedure, but more recent results is a 90% success rate. In congenital heart disease, it's much more complex, often the anatomy, the scar. There's many factors that reduce the success, but still really effective at 80 to 85% of arrhythmias. There is a risk for recurrence after a successful ablation as the healing continues and swelling decreases from the ablation. Generally about a 5 to 10% recurrence rate, but 90% permanent cure. Of course, we have to talk about the risks of the procedure. It's not an open heart surgery, but it does involve catheters in the heart, so of course there are potential risks. One of the most common is a minor injury to the blood vessel, such as a hematoma at the vein where we entered, or potentially an arteriovenous fistula that can form if there's arterial access. More serious complications are approximately 0.5%, less than 1% chance of a serious complication. Heart block is what families seem to stick to the most. It's the most tangible for them and the most frightening, that they might need a pacemaker. In the literature, this is reported as about 0.5 to 1% chance risk of heart block. But that's all comers, including patients with abnormal anatomy. And so in practice, the risk of this is much lower. Again, one of our most common or most feared complications as well. So we're acutely aware of this, and we're constantly watching the conduction and can get warning signs if we're too close. There is a risk of pericardial effusion or cardiac perforation or embolus or stroke, and we have ways of minimizing those risks, but we can't reduce them completely. Finally, there might be injury to coronary artery injury from the ablation itself and potential complications from anesthesia. So when to refer? It's going to be very patient dependent and it's going to vary, but you don't have to wait for the extreme cases is one of the major things I would like for people to take away from today. It's a great procedure, of course, for hemodynamically unstable arrhythmias, great option. But even if a patient is stable and doesn't have a risk of sudden cardiac arrest, they might have enough arrhythmia or severe enough symptoms that it interferes with their life or potentially results in ventricular dysfunction. If arrhythmias are refractory to medications, if patients are on a beta blocker but they're having breakthroughs, or if there's a contraindication to medication, if they're an asthmatic, they shouldn't be on a beta blocker, or if they have a severe anaphylactic food allergy, chronic beta blocker use can blunt the effects of epinephrine and may make treating anaphylaxis very difficult. If a patient has had an adverse reaction to a medication or simply is averse to being on chronic medications, that would be a great reason to talk about an ablation. Again, we talked about the potential for job disqualification. Wolff-Parkinson-White is a big one. So again, this is one form of SVT that does carry a risk of sudden cardiac arrest from pre-excited atrial fibrillation. And of course, if a patient has already had that, they must have their pathway ablated. If they have suspicious syncope that doesn't seem to be a typical vasovagal faint, we're going to be concerned about pre-excited atrial fibrillation. If there's a high-risk pathway, that may also be, that is definitely an indication. We try to figure that out with exercise stress testing to see if their pre-excitation is still there at fastest heart rates. Not perfect risk stratification, though. We electively do these procedures. The literature and data over the years have shown that this can be safely done in patients greater than 15 kilograms. Most centers will typically do it in patients who are greater than 20 to 25 kilos, which is pretty much school age, 7, 8, 9 years of age and bigger. The risks at that point are the same as that for an adult. In an urgent indication, we can do this procedure in any age or size. There might be an infant with WPW and either refractory arrhythmias or ventricular dysfunction, and certainly those rhythms can be ablated with potentially higher risks, but can be very successfully treated with catheter ablation. So in conclusion, pediatric arrhythmias, the common ones, particularly SVT, PVCs, even non-sustained VT and sustained VT, are usually not life-threatening, but may be significant in terms of disruption due to symptoms or potentially even affecting the hemodynamics. Management options do include simple observation, medications, and ablation as first line of therapy. Ablation is safe and very effective for elimination of many arrhythmia substrates in pediatrics. Thank you so much for joining and listening today. Please feel free to unmute or send in a message or send me an email at any time. I hope everybody has a great 4th of July weekend. I do want to mention as well, I'm based out of Children's National Medical Center, but I do clinics both here at DC as well as Fairfax at an outpatient clinic on Comaker Street. I also have an outpatient clinic at Virginia Hospital Center once a month. And again, we are doing procedures now at Fairfax Inova Hospital. My colleagues also in electrophysiology, Drs. Barul, Moak, and Kultman, have clinics around Maryland. So we do come to the suburbs and have places in most areas. So not necessarily everyone would need to drive to DC. As questions arise, feel free to *6 to unmute on your phone. Okay, well, thank you so much for joining. I appreciate everyone's time and hope you have a great weekend.